Welcome to CR Arthritis 2025. My name is Ellen, and I'm the Programs Coordinator at Arthritis Consumer Experts. Today, I'm joined by none other than Dr. Jackie Whittaker. Dr. Jackie Whittaker is an Associate Professor in the Department of Physical Therapy at the University of British Columbia. She is also a Senior Research Scientist at Arthritis Research Canada, and she is recognized as a Clinical Specialist in Musculoskeletal Physical Therapy by the Canadian Physiotherapy Association. Jackie recently gave a pre-course session at the Arthritis Health Professions Association on the topic of StopOsteoARthritis, SOAR for short, which is a virtually delivered knee health program for persons living with increased risk of OA due to activity-related injury. Jackie, welcome to our program and thank you for joining us.
Thanks, Ellen. It's great to be here. Super excited.
Jackie, can you share a little bit more about yourself and perhaps touch on what is SOAR?
Sure. So as you indicated, I'm a physiotherapist. I'm also an associate professor, so a researcher in the Department of Physical Therapy at UBC. I worked as a physiotherapist for about 20 years before I decided to go on the academic journey. So I've worked with this the patient population that we're addressing SOAR with for quite a long time. Yeah, I don't know. I'm based in British Columbia, and it's a beautiful day here, and everything is sunny. So that's who I am, and I've been really fortunate to be involved with Arthritis Research Canada for several years now, as well as the Centre for Aging Smart at UBC, which I will mention as well because they've been excellent in providing support. So what is SOAR? Well, basically what SOAR is, so what we know is that people that have traumatic knee injuries have quite an elevated risk for developing osteoarthritis. And what's sort of interesting and a little bit different than maybe other forms of osteoarthritis is that the most common age to injure your knee is between the ages of about 15 and 25. And people that have a traumatic knee injury, about 50% of them will go on to develop osteoarthritis within about 10 to 15 years. And so what that means is that we have people as young as 20, 25, 30 that are developing osteoarthritis and then living with osteoarthritis for a good proportion of their adult lives, which is much different than we typically think about with osteoarthritis. Typically, we have in mind an older person who's maybe in their 60s or their 70s that are living with a disease. So because we know that traumatic knee injury can dramatically increase the risk for osteoarthritis, there's a window of opportunity. There's a 10-year gap between when the injury occurs and when the onset of the disease might be. And, it moves. It's not always 10 years. Sometimes it's sooner, sometimes it's later. And for 50% of people, it doesn't happen at all. But there's definitely a window of opportunity. And so what we've really been doing in our research group now for quite a few years is really trying to identify who are those people that are going to go on to be at higher risk of developing osteoarthritis. And then what can we do in that window of opportunity after they've had their injury and had the treatment for their injury, but before they develop osteoarthritis, to either prevent osteoarthritis altogether or maybe worst case scenario, reduce the severity of the osteoarthritis that they develop. So is there anything that we can do to improve those long-term outcomes? So that's what SOAR is it's really an intervention that occurs after somebody has had an injury and received treatment for their injury, but before they develop OA, with the goal of really helping people to self-manage their knee health and look after their knees so that they either don't develop osteoarthritis or if they do, it's in a lesser form.
Wow, some of the stats that you gave us, Jackie, of 50%, so 1 in 2 individuals post-traumatic knee injury will develop early onset. Can I call it early onset?
Yeah, we would call it early onset. Yeah.
Early onset knee osteoarthritis. Thinking about that statistic, I'm quite shocked. What can you tell us or hypothesize perhaps why is that so high that 1 in 2 individuals are at risk?
Well, I think that when people have a traumatic knee injury, a lot of knee injuries, and we know that there are some knee injuries that have a higher risk than others, but even, injuries that we don't typically think of, like a tear of maybe one of the collateral ligaments or a dislocation of the patella, actually has quite an elevated risk for osteoarthritis. And I think, it comes down to what is our understanding of why does osteoarthritis occur? And I think the post-traumatic form of osteoarthritis. The understanding is that there's been some kind of a damage to the cartilage, to the bone, some disruption to how the joint accepts and distributes load, and then that drives degradative changes. It drives the cells within the cartilage, the chondrocytes, to start behaving oddly and causing degradation, which ultimately results in osteoarthritis. So I think with post-traumatic forms of OA, we really think it's due to the injury itself. And I would also say perhaps how the mechanics of the joint change after the injury, and don't return to normal. And I think that's the thing that's really interesting is we typically think, okay, we've had a knee injury. And as I said, we tend to be young when we injure our knee. The reason we're talking about the knee is because the knee is where we have most injuries. So a knee is a really common place to have an injury. We typically injure it when we're young, and we typically do it when we're doing some sort of a sport or recreational activity, sometimes with our occupation or our work, but the majority of these injuries occur while we're playing sports or being physically active. And I think when we have those injuries, if we reflect kind of back on maybe experiences we've had, we think, okay, we've had the injury. Maybe we see a physician or we see a physiotherapist. We do the rehab, we do the things that we need. And then life is good and we carry on and we think, okay, we're back to normal. Even if it was a more severe injury, like maybe a tear of our anterior cruciate ligament, which is a ligament deep inside the knee joint. We have maybe some rehab, we have surgery, we have rehab again. A year goes by, we do all the right things and we think, okay, now we're back on track and we just carry on and live our lives as normal. But there are lasting consequences, not just to the structure of the joint, but we know people 15, 20, 25 years after an ACL tear still will exhibit weaker muscles on that side than the other side. They'll recruit their muscles differently. Their mechanics can be different. And I think for a long time we thought, oh, well, we can do things to restore the normal mechanics or restore the normal muscle strength. But I think we're realizing now that those injuries, they have lasting effects. They aren't just a one-time, have it, done with it, move on, but they aren't self-limiting and that there are these longer-term consequences. And so I think really the goal of what we're trying to do and what SOAR is doing is really to equip people with the knowledge that, hey, I had a knee injury. I might be at greater risk for certain things down the road. So I need to know that, because if I don't know I have a risk, then I'm not going to do anything about it. And then we help them to try to go, okay, so what can you do to minimize your risk? And that's challenging research to do because it's really hard to follow people for all those years to know if the thing that we did back in, I don't know, 2022 has led to a dramatic change 10 years later. But I think that there's enough evidence out there now to give us a sense of some of the key risk factors for OA and post-traumatic osteoarthritis that we would really want to address. So yeah, I mean, I think it starts with trauma. It changes the way we load the joint. There's lasting weakness. There's lasting changes in the mechanics. And people need to know how to manage that.
It's incredible because your work really looks at not only the injury, but things that may have predisposed individuals before the injury. What happens after the injury in that window of opportunity. Can I ask then, so I'll use normal rehabilitation, right? We have an injury in our knee. We go to rehab, like you said. We're all good. Most of us are all good. We return to playing recreational sport, return to recreational activities like hiking. Does SOAR in that case, on the other hand, is there a component of SOAR then that addresses the long-term effects? Are the exercises supposed to be done long-term?
Yeah, I mean, it's a great question. And, for somebody living this journey, I'm not sure that they distinguish, let's say the pre-surgery rehab, the surgery, the post-surgery rehab, the SOAR program as separate entities. I mean, I get that there might be different people delivering that care, etc. But to answer your question, most rehab, most physiotherapy, whether it be after a surgery or even if there wasn't a surgery, let's say physical therapy for an injury, tends to address the injury. And this whole concept of, okay, you're fine and you move on. I mean, that's kind of a really interesting concept. Are you discharged? What are the criteria for that discharge? Often we'll say, oh, well, your leg strength is within 85 or 90% of your opposite leg, so that's a tick and we can discharge you. Or you're allowed now to go back to sports. And maybe we combine that with some patient-reported outcome measures and some functional tests like hopping, and we go, okay, yeah, you're good. You can go off on your own. But we do that and we still find these deficits in strength many years later. We know these people are at increased risk of re-injury. We know a certain of them percentage will return to sport. They'll struggle with sport and then they'll withdraw from sport. They'll become less physically active. They'll gain weight. And all of those things lead to that downward spiral that could potentially end in osteoarthritis and other things. And so what SOAR does that's different, I think, than that typical rehab, though there's nothing to say that the principles of SOAR could not occur during normal rehab. But typically normal rehab is focused on either returning you to sport or physical activity or addressing the concerns that you had after your surgery. Do you have full range of motion? Are you back to doing the things you want to do? Do you have strength? What we don't typically do in physio is, okay, inform people what the long-term consequence of their injury is. We don't tend to do that. And secondly, we don't tend to take time to teach them how to manage their long-term knee health, both from a perspective of what should you be doing ongoing, what things should you be watching out for, and when should you re-engage with me or another healthcare practitioner if things aren't going well. Instead of waiting for 10 years and re-engaging the healthcare system when you now have a diagnosis of OA. So are there things that we could be doing in between? So yeah, I do think SOAR sort of plugs a gap in care, but I don't think we have to differentiate it or make it separate from the other care. We've done that for the purposes of our research project, but when I talk about SOAR and the principles of SOAR, I often talk about it to people that are currently delivering care, and I like to think that when they leave that conversation, that they're thinking about introducing some of those principles to patients that they're treating for their knee injury.
Absolutely. Like really looking at the continuity of care. And I love how you've been able to distill this entire program, SOAR program, down into certain principles that you're able to teach and very pragmatically teach others to use in their practice, whether they're allied health professionals, rheumatologists, right? Things that we should be keeping in mind when we're working as in the field. Thank you, Jackie. And, you know, quick question about getting injured. Is there any way to avoid getting injured while playing sports?
Yeah, absolutely. So there's really strong evidence, particularly related to the knee. We know that exercise-based training programs, whether they be warm-up programs or programs that people do alongside their sport-specific training, we know they can reduce knee injuries up to 55, 60%. So absolutely, injury prevention programs that are training programs are an excellent way to reduce injury. And I mean, really, that is the gold standard. If we can prevent the injuries from happening, then we don't have to worry about post-traumatic osteoarthritis. We don't have to worry about withdrawal from sport, inactivity, weight gain, all those comorbidities. That all goes away, right? At least from the cause of the knee injury. So absolutely, I think that if you or others or people listening are either participating in sport themselves or have family members that are participating in sport, really need to be advocating for the implementation of those injury prevention programs. They exist now for pretty much every sport out there, and they apply not just to lower extremity injuries, but also to upper extremity injuries. So absolutely, there are things that we can do to prevent injury. And I think we actually know a lot about preventing injury. Where we've struggled a little bit with preventing injury is, I don't know if we, at least initially, had as much of the implementation scientists involved as we were developing that work. And so we're playing a little bit of a catch up now in really working with the groups, the end users, the sports associations, the athletes, the parents, the coaches, the whole sports system and sport community and recreational sport community to implement those programs widespread. And when we do that, we do see dramatic decreases in injuries. Injuries still occur, but they happen at a much lower rate.
No, I've recently had the chance to review the FIFA 11 guidelines for warming up and getting yourself ready. Very basic. They're not, I do want to emphasize, they're not like something that you've never seen. This is not, they're follow along programs, very practical. And Jackie, what I'll do is I'll make sure to get some other links from you that we'll share with our viewers. They'll be linked at the bottom of this video. Um, but Jackie, now that we've talked about your work, the prevention side, are there any other innovations in your specific field that you're really looking forward to?
Yeah, I mean, innovations, I think it's interesting. I think when I think about innovations, I think about, patient populations we're working with. I think about the ways that we're delivering care. I think about who's delivering care. So, for people, you mentioned it at the start, SOAR is done virtually. We don't have people come individually because part of it is we want to be able to have as many people as possible to have access to this knowledge. We also want people to learn how to look after themselves and not be entirely reliant upon a healthcare provider. So we kind of sit there on their shoulder as they're learning how to increase their exercise load and decrease it and adapt it if there's a flare up and address this problem and that problem and provide advice. And I do think that virtual care, I don't know if it's an innovation anymore. I think a lot of people are doing it. We're all doing it. We see the benefits of it. It doesn't mean that there isn't a time and place for in-person care, and I think there can be. And we've looked at that a little bit within the construct of SOAR of, who would really benefit from that in-person piece. But I think of that. I think of the virtual environment, and just having a conversation on a video conferencing platform like we're doing right now is part of it. But I think there's even more innovations beyond just that, whether it be, virtual feedback or all the innovations that are happening around virtual technology and virtual monitoring. I think those are all very, very, very interesting. Patient populations, I think, is always very important in front of mind. So much of the research that's been done in my world of knee injuries and treating knee injuries has been done on, probably college level and elite athletes who are not representative of society. They're a very unique group, a very important group, but they're not the only people that have injuries or long-term consequences. They're also people that often have a lot of resources. So I think there's a lot that we can do to make sure that the masses have access to this knowledge and package it in a way that is digestible for everybody, whether that be language, whether that be education level, whether that be cultural, whatever that might be. I think there's so much work we can do there from an innovative perspective. And I also think we can start thinking about the delivery of this care. We've got these professional silos, right? I'm a physiotherapist, you'll be a physiotherapist, or you are a physiotherapist, excuse me. We've got physicians, we have athletic trainers, we have, you name it. At the end of the day, the people that need to be treating themselves are the patients, right? They need to, in this case, really know how to self-manage. And for sure, that might mean part of that self-management might mean knowing when to re-engage the healthcare system when they're beyond their needs. But I think there's a lot that can be done there. And I know we've started to consider some innovative models for delivering care because we have healthcare shortages all across the country and around the world. I know as physiotherapists, we have a massive shortage of world physios around the world, or physiotherapists around the world. And so we've started looking at some student-led models for delivery of care. And I think SOAR fits very, very nicely with that. I think the innovations I'm interested in are maybe not so much a specific treatment, but it's really about how we get the information that we've come up with out to the people that actually need that information.
Jackie, I love when you put your implementation scientist hat on and you're able to place your research and the future of research in the kind of the larger landscape and kind of show us as an audience where we are and how things fit. And in our short time together today, what I've really learned is your research is, as you said, like more specific to a certain population, but the takeaways from your research are that injury causes long-term changes to how we move and our biomechanics and how we absorb load. And that can lead to something down the line, maybe it's 10 to 15 years out. And what can we do that's pragmatic instead of, you do this rehab and then you have to do that rehab 5 years later. Like what pieces can we distill down our research to then put in the long-term picture of care? So I'm really starting to like see those pieces and they're coming together for me. And thank you, Jackie,
Oh,
for
no
sharing
worries.
your time and expertise with us. I cannot wait to learn more about SOAR and those practical pieces of advice and use them in my own practice.
Oh, awesome.
And with that, we thank everyone for joining us today. We thank Jackie for her time, and we encourage you to all to tune in for another episode of CR Arthritis for another exciting chat with different rheumatologists, different care providers, as well as trainees. And with that, thank you guys very much for joining us.